Dear Chairman, dear Matteo, thank you very much for this kind introduction. I'm very happy to be here, and I would like to thank the Society and to the reviewers to accept our abstract. So these are my disclosures. Well, if we look to the ventricular aneurysm, we know that this is an important late complication of MI, with incidence about 10 to 30% after STEMI. It's associated with malignant arrhythmias and a progressive heart failure. And we also know that the risk factor for sudden death and the 5-year survival without surgery is accounting only 30 to 70%. Now, we know we have a lot of surgical techniques. We can roughly divide them into two categories. The first one is linear LV reconstruction, or linear repair if you want, which is accounting linear resection and closure, as described firstly by Cooley and its modifications. The second was a so-called geometric LV reconstruction using a bursting suture on the neck of the aneurysm, as described by Jayton, and which is mostly not using a patch, and the door technique, which is using a patch in every cases. We know also that up to date there is not clear benefit of a geometric technique over the linear technique, especially in short and long-term survival. Therefore, we wanted to have a look into our data, and the aim of the study was therefore analyze the outcomes of LV reconstructive surgery, especially as long-term survival, due to different LVA localization. I will touch this point later, and a surgical technique. So if we look into our cohort, so between 2006 and 2019, 195 consecutive patients with the age of 64 years, and 20% of females were operated in our department with these techniques. So it's a clear retrospective single-center study. And as I already mentioned, the primary endpoint was a long-term survival with overall survival, but also according to LVA localization. So we, let's say, categorically divided in two categories based on anatomical and physiological characteristics. It means anteroapical and inferolateral. And also we had a look deep into the cohorts with mitral surgery and without mitral surgery. Follow-up was 98%. Only 4 patients were lost to follow-up. So we had a median of 6 years, accounting 1,255 patient years. So you see here preoperative data, just roughly 7% redo surgeries, 12% stroke preoperatively, and of course apparent CAD was in 97% of patients. MR, so mitral regurgitation, greater than the moderate was in 15% patient, and median Euroscore 2 was 4.4. And now the localization, so anteroapical aneurysm were present in 75% and posterolateral in 26%. So on the image you can see one huge inferolateral aneurysm. So going to technique, unfortunately don't have the whole video, but we try to make a video from photos and some. So you can see the same patient with this huge aneurysm exposed already on cardiac arrest, and here you can enjoy putting the bursting suture on the neck of the aneurysm. We use basically 2O proline, and then normally we already had a look if we have an MRI preoperative, at least to echo, on the size of the patch which has been done, cut it and fit it on the defect, and try to diminish the neck of the aneurysm about 10 to 20%. In some cases, we also use a catheter, which I show you in the next image, just to measure the end diastolic diameter, volume of the ventricle. So now it's a closed defect, and then the remnants of the aneurysm just trimmed and then sutured over with double-layered, basically 2O suture with felt support. So this is the image here. This is not the patient from the series because couple of patients has been operated minimally invasive with anteroapical aneurysm in the last years, but you can appreciate here it's just simple Foley catheter, and if you count that, basically the formula and door procedure is 60 to 80 milliliters per square meter of body surface area, so you can fill the up to 150 mils, and you can really try to get correct volume of the left ventricle. Now, if we will have a look now to the results. So 30-day mortality was 11%, so 21 patients died. We had 81 survivors with median NIHA functional class 2, so there is preoperative was 3, so they are doing better. The Kaplan-Meier survival estimator was 8.3, and you can see on the Kaplan-Meier curve that despite the fact that really a lot of patients are dying with the time. We had, we did a risk analysis, uni and multivariable. You can see that in univariable risk analysis, we could identify more risk factors for mortality. In multivariable, it's just a rhythm preoperative. So if they were in atrial fibrillation or in sinus, perioperative MI quite strong, and postoperative dialysis also quite strong predictor for mortality. Now, we look into the different groups. So we divide, as I say, to anteroapical versus posterolateral aneurysm. You can see on the left-hand side the Kaplan-Meier's survival of the patients. You can see here that, of course, the group of posterolateral is quite small, 50% at risk beginning, and of course at 15 years we have a very small number of patients. However, in the comparison of these groups, no statistical difference could be revealed. If we had a look into comparison between liner, so let's say a Cooley, the classical liner repair versus geometric repair, either Guyton or door reconstruction, you can appreciate now the group 103 against 92 patient at risk starting with time 0. And then the survival over time up to 15 years, of course, here again quite small numbers. However, no statistically significant difference between these two groups. The only interesting difference we could find, and really strong statistic difference, is if we had a look on the patients, they required mitral valve surgery. Mostly in 85% was a repair or replacement, against the patients without MV surgery. Again, the groups are not matching that much with numbers, but 135 against 60, and you can see the different survival, so much more better without surgery, statistically significant. So let me conclude. So we were able to show an acceptable operative and short-term results of these patients after very complex LV reconstructive surgery. In survivors, we saw a significant improvement of symptoms and quality of life. And in this particular population, we can probably say that Euroscore 2 strongly underestimate the mortality, the 30 days mortality, because expected was 4.4% and we observed 11%. Despite these facts, the long-term survival of these patients remains very poor. So you could see it really on the Kaplan-Meier, which goes steeply down. And we could not be able to show any difference between the localization, so it means anteroapical versus posterolateral, and also in a kind of repair. So linear versus geometric, they were doing all the same in long-term mortality. However, we were able to find a really significantly worse survival in patients who required any concomitant mitral valve surgery, means repair or replacement. Thank you very much for your attention.